In this audio lecture, we're going to start our coverage of our disorders that decrease cardiac output. And so this is in the cardiovascular disorder chapter. We're going to start with infective endocarditis. So what is infective endocarditis? Um, Remember that the endocardium is let me pull out my pointer here. So the endocardium is the structure that lines the chambers of the heart, right? And this is continuous with the endothelium that lines the blood vessels. And so infective endocarditis is an infection of the endocardium. Now, specifically, this could be down in the ventricle, down in the chamber here. Um, I haven't read much about it actually occurring in the atria, but it can occur on the leaflets of the valves. Right? And so when an infection occurs and it's entered the circulatory system, it can begin to infect other connective tissues, such as the endocardium. It's caused by several different strains of Streptococcus, which is a bacteria. If it originates in the mouth, such as the case when you get dental work, this allows an entry point for bacteria to get into the circulatory system. It would be due to Streptococcus viridans. Now, we have Streptococcus aureus living on our skin quite substantially, actually, and then Streptococcus enterococcus, right, which is it resides in our digestive system. Now, any point at which these bacteria get exposure to our circulatory system, it can lead to an infection. So, what happens when this bacteria gets into our circulatory system? Well, this causes endothelial damage or endocardium damage or just sticky points on connective tissue like the valves. And so when you get these sticky points, this allows for platelets to stick to that structure, that surface, right? So normally our endothelial cells are very smooth and they allow blood to move past without causing major damage. But in the case here, we have an infection, and that infection is leading to rough spots. And so we could get platelets sticking right over here, and that is a major concern, right? So actually, here is the example where we get a bacterial infection. It enters our circulatory system. Here's the bacteria right here. This resembles more of a virus, in my opinion. Um, but these are platelets, right? So the platelets, since they become activated, they begin to stick to each other, right? And they form these structures. This is in the valve, but these plaques that form, these are referred to as vegetative plaques. And so vegetative plaques are oftentimes found on an infective endocarditis. Um, these plaques cause major disruption to blood flow, and they can break off and potentially lead to embolisms, which I'll discuss in a second. Okay. So, but what happens is the platelets stick to the walls now, and so they form a thrombus, which is a precursor to a blood clot. And so a thrombus forming on the vessel wall could allow it to break off and potentially travel downstream to subsequent capillary beds. So when these vegetative plaques form, they disrupt blood flow. So specifically, this is looking at the aortic semilunar valve. So this is the leading from the aortic semilunar valve right here. And movement of blood out of the left ventricle through that left aortic semilunar valve can disrupt blood flow leaving that ventricle. All right, so we get these thrombi forming in circulation, and generally they're going to develop on either the vessel walls, the valves are inside the chamber. The vegetative plaques form. So the vegetative plaques form because now we get the accumulation of bacteria and then additional blood cells like red blood cells, leukocytes, some platelets are going to begin to increase in their formation there. Um, Now, these vegetative plaques can really be a concern, right? Because then they can then break off and go into circulation, and this leads to all kinds of problems. One indication that vegetative plaques have begun to broken off is if you get petechial spots. Petechial spots are little red dots, right? And they are from either structures that are part of that vegetative plaque, like thrombocytes or erythrocytes going off and blocking, not so much erythrocytes, but the thrombi are going off into circulation and they're blocking blood flow, leading to a little red dot on your skin. We could get hematuria. Hematuria is blood in the urine. And so usually if you have blood in your urine, it's not normally there because our glomerular filtration membrane, glomerulus, is good at keeping out whole red blood cells. But now we have an inflammation process leading to that increased permeability of the glomerulus, leading to blood in the urine. And then we could potentially, this is should be another, this little sub dot should be over to the right here. We could get potential embolisms, right? So an embolism is a blood clot that has broken off that is traveling through our circulatory system, right? The major concern here is either the blood clot traveling to our brain, blocking blood flow to a path in our brain, or a pulmonary embolism. So a pulmonary embolism is when a blood clot travels to your lungs and then it stops blood flow to a region of your lung. Now those could be more or less harmful depending on what part of the lungs they're actually residing in or relocating in. So we need to be aware of these disorders. And so infective endocarditis could be a very fatal disorder, right? So it is if it's untreated, it can lead to a fatal development. So what are some risk factors for infective endocarditis? Prolonged intravascular use, intravenous drug use. So anytime you stick something foreign inside of a blood vessel, it introduces the possibility for bacterial infection. And so for catheters, it would have to be a prolonged catheter, right? So allowing bacteria to accumulate on the catheter and then working its way into the catheter down into your circulatory system. Intravenous drug use should really be quite obvious because oftentimes individuals who partake in drugs that require intravenous drug use don't use clean needles. And so that is a very likely possibility of getting infective endocarditis from this, if not worse. Valve disorders. So valve disorders already don't open up properly or they don't close properly. Well, this creates really a disruptive blood flow, allowing things to accumulate on the valves themselves or in the endocardium, as you're going to see with some of these valve disorders that we will discuss in another audio lecture. And medical devices like defibrillators or pacemakers or stents can introduce bacteria into the body. So it's really important that before we put these devices into the body, they are sterilized. And almost 100%, I can't imagine any kind of medical treatment being conducted where you insert a medical device that has not properly been sterilized. Okay. Untreated infection, right? So let's say that you had strep throat, right, and you never got it taken care of. Well, that could lead to infective endocarditis because now the bacteria really take hold and they start to get stronger and stronger. Or if you don't take a series of antibiotics fully. So that is the one thing that I always pass on in every single class is that if your doctor prescribes you antibiotics, take the entire dose, regardless of what other conditions it's doing to your body. If it gives you temporary diarrhea, that's better than developing infective endocarditis and contributing to antibiotic resistance among bacteria. Okay. We have a few more risk factors. Anything that creates turbulent flow in the heart, right? So the valve disorders would fall under this category as well that I talked about in the last slide. And so anything that would create turbulent flow. So coarctation of the aorta is just going to be narrowing of the aorta. Another term for that is stenosis of the aorta. Congenital heart defects can lead to the infective endocarditis just because they allow turbulent blood flow to happen. And anytime you have turbulent blood flow, the endothelial damage could result. And if there's bacteria in the system, these bacteria could generate these vegetative plaques. And so we have a couple congenital heart defects. So coarctation of the aorta is a congenital heart defect as well. But in addition to these, we have like tetralogy of the phalate and then Marfan syndrome. So tetralogy of the phalate is a displacement of the aorta, okay, towards the down the interventricular septum down here. You actually have a hole connecting the left and right sides, and so what happens is the right ventricle shunts blood to the left side of the body, and it hasn't been through the lungs yet, and so it actually is deoxygenated blood. Marfan syndrome leads us to susceptible to aortic aneurysms because it's connective tissue disorder. And so this can lead to dilation of the aorta or a weakening of the aorta. Now, the manifestations of infective endocarditis include flu-like symptoms, and so this stuff is going to be like fatigue, malaise, general ill-feeling, fever, maybe some other conditions like vomiting and diarrhea. Hallmark symptoms of really an infection, but it's just an indication that something is not going right in your body. We could develop embolisms. So embolisms, again, are when a blood clot breaks off and it travels to a distant site. When that happens, it blocks the capillary bed. So the blood clots are bigger, even if it's just a fragment, are bigger than capillaries. And so when we block those capillaries, we impair function of whatever that structure is. And so specifically, if you're looking at the brain or the lungs, both those are essential towards a normal operation of our body. We can develop heart murmurs. Heart murmurs are going to be a result of impaired blood flow through the heart. And so this would be like swooshing sounds, anything in addition to the lub-dub. Petechial spots, these are petechial spots right here. These are little spots where a blood clot is essentially, or a vegetative plaque is essentially broken off and blocked the capillary bed, allowing blood to pool in this area. Splinter hemorrhages are another idea, and so these are going to be just damage to the cuticle over here, or beyond the cuticle. So anytime you have red streaks that are going up into the nail bed, that is an indication. Hematuria, again, is blood in the urine. And Osler's nodes. Osler's nodes are painful spots on your hands and feet, and these actually are found in pretty much a number of cases of infective endocarditis. And then one other manifestation here would be edema, right? So edema, if it's occurring in the venous circulation, which is where a lot of embolisms actually occur at, and then they travel to the pulmonary circulation, this could result in blocking venous return, allowing blood to fill in that interstitial space. Not blood, but fluid. How do you diagnose infective endocarditis? Patient history and physical examination. Okay. So you're going to be asking questions that would lead towards a bacterial, or look for questions that are leading you towards a potential bacterial infection or some sort of infection. We'll want to take a physical examination, and so this would be like listening to breathing, listening to your heart, then taking blood pressure and heart rate, standard lab tests, and so we're actually going to measure a rheumatoid factor. And so one of the causes of infective endocarditis is if you have developed strep throat and then you didn't get it treated, it develops into rheumatic fever. And then you develop antibodies specific for the rheumatoid antibodies. So these rheumatoid antibodies aren't necessarily an indicator of infective endocarditis, but they are an indicator that you developed an immune response to previous infection. Now, urine, again, we're going to look for hematuria. So in addition to these other tests and information, we're going to measure an ECG. So this is an ECG, so PQRST waves. Okay, looking at atrial depolarization here, ventricular depolarization here, and then ventricular repolarization here. And so what we're going to be looking for is artifacts in the ECG. We'll take a look at the heart and see how it's pumping and how blood's moving through it. I'm using an echocardiogram. This is using ultrasound technology to visualize the organ in the body actually functioning. And then one test that is not listed over here, that is listed right here, is we're going to be looking at erythrocyte sedimentation rate. So an erythrocyte, so as you take a sample of blood, erythrocytes settle out, right? They come out of solution, you get the plasma going to the top with the antibodies. The clotting factors sit down here in this little buffy layer. But the rate at which the erythrocytes settle out. And so you look at this, and then the faster the erythrocytes settle out, usually that's an indicator that you have an inflammatory reaction in your body. And which would happen if you have an infection, right? So, so the faster that erythrocyte sedimentation rate begins to occur, as an indicator that your erythrocytes are displaying a hallmark symptom of inflammation. So how are you going to treat infective endocarditis? Well, first of all, you need to ID the infection. So is it a bacteria? Is it a viral? And so you need to identify the source of infection before you begin to treat it. You begin treating with long-term agent-specific therapy. So if it's a virus, treating with antiviral therapy. If it's a bacteria, antibiotic therapy. Okay. Then other than that, providing just comfort. So bed rest would reduce the demands in the heart. Oxygen therapy would load up the hemoglobin with oxygen. So one thing right now is that cardiac output is reduced, and so blood flow to the lungs is reduced because blood is not properly flowing out of the heart. And so we might give analgesics and antipyretics to take care of any fever and discomfort in the terms of treatments. Okay. And the last case would be surgical intervention. So if you get the infection taken care of, but it's caused long-term damage due to fibrosis occurring. So anytime inflammation occurs, this is the issue with inflammation, is it causes tissue damage and causes fibrosis to happen. And so if the fibrosis, especially on the valves, is too severe, they can't repair it either through a cadaver donation or so if they can't so they get rid of the infection, and then the damage is just irreparable. They could replace the valve from using either machined artificial valves or valves from a cadaver like a pig. And so pigs are commonly used for tissue transplants because they're pretty similar to us. So with that said, this is the end of the infective endocarditis lecture. I hope everybody has a nice day. Until next time. So now it's time for the hot wash. By the end of this lecture, you should have been able to gather what is infective endocarditis, what causes infective endocarditis, okay, what exactly is it, how does infective endocarditis decrease cardiac output, and remember that if anything that reduces flow out of the valves, okay, reduces cardiac output. And so if it reduces flow out of the valves, that is an increase in afterload and leading to a decrease in cardiac output. How are the manifestations associated with this disorder? Okay, so can you explain to me why petechiae spots happen and why we see hematuria possibly? Why splinter hemorrhages are an issue, right? Among the other manifestations. How is it diagnosed and how is it treated? Okay, so these are all things that you need to be aware of at the completion of this lecture. So with that said, we'll see you next time.